Hello and welcome to the Love Mia Vita podcast, sponsored by Fem Pharma. I'm Jerry DiPiano, founder and CEO. Thank you for joining us as we discuss all aspects of women's healthcare. Please note, this podcast is for educational purposes only. Always refer to your healthcare practitioner for personal advice. Hello, Catherine. I'm with Dr. Catherine Sherif, and this is the Love Mia Vita podcast, which you are listening to once again, sponsored by Fem Pharma. And Dr. Sherif is a professor of medicine at Thomas Jefferson University in Philadelphia. And she is a primary care practitioner with a specialization in women's health. But Catherine, I'm sure I've missed something. So for our guests that may not have met you on a previous podcast, please share more about your background.
Thank you, Jerry. I'm so glad to be here. I'm so glad we're connecting today. My background is that I'm an internal medicine physician, and I also do a lot of office gynecology and have a special interest in hormones. And I really do believe that sex hormones, which we usually associate with periods and the reproductive organs, they have an effect on everything, on your brain, on your heart, and on your kidneys. And so, if we really want to understand the health of women, we need to understand the role of sex hormones.
Absolutely. Well, thank you for sharing that with us. And Dr. Sherif frequently co-hosts with me, so check out some of our other podcasts where Catherine and I talk about any number of topics that are relevant to women and women's healthcare. But today, our topic is quite interesting, and it is the topic of mammograms and what they can tell us about our heart health. So, Catherine, we know that cardiovascular disease is the leading cause of death, followed by cancer, breast cancer, for women. And now there's some interesting information about how something called breast arterial calcifications can be a guidepost for us in understanding more about how that can impact a woman's heart health. So, first of all, what are breast arterial calcifications?
So, this is a great example of how something that we consider in the field of gynecology, breasts, and getting a mammogram, how it actually informs us about your cardiovascular health. Um, so, a little word about a mammogram or a little introduction to mammogram. When you have a mammogram and you have an x-ray of your breast, if the breast is mostly fat, and as we get older, tissue disappears and is replaced with fat, um, it's easier to interpret the x-ray because fat looks black. And then something that's not supposed to be there may look white. And there's a contrast, and that's how you can pick up something that's a problem. Now, the reason we don't do mammograms on 25-year-olds and we wait usually till people are 40 is because when you're younger, you have so much tissue and it looks white and it looks like this net of white stuff, and it's hard to x-ray it, unlike fat, which looks black. So what's abnormal, what's normal, and that's why we wait till you get older. Now, breast arterial calcifications are very interesting because, like every other organ in the body, the breast has blood vessels in it. And the blood vessels collectively are called the vasculature. So, vascular health is the health of the blood vessels in your body. And it turns out that we can see blood vessels, the blood vessels that we can see in your mammogram can tell us something about your overall cardiovascular health. So, calcifications will look like white lines um, on a mammogram. Sometimes they're called tram tracks or train tracks, and they will be these white lines that follow the outline of an artery.
So, interestingly enough, you mentioned this the 30% of women will get their mammograms between the ages of 40 and 60 years of age.
Yeah.
So I would imagine that this is a good baseline, right? So if you're 40 and you're having a mammogram and you're looking for a breast arterial calcification, you see none, or maybe you start to observe changes over time. But in any event, when you go in for your first mammogram, that could be your baseline.
Yes. That could be your baseline, and you may not see any calcifications at all because the older we get, the more calcifications you see.
And in the younger age group cohort, based upon what we have seen in the literature and in the scientific literature and in studies that have been done, the older age group cohort, so as we continue to mature into perimenopause, menopause, then you will see an increased incidence. So maybe about 10%. Does that sound about right?
Yes.
And 50% of those, so I guess 50% of the 10% may have some sort of pre-existing cardiovascular risk factor. So really important that women have their BAC, right? So examined and reported. So is that something that is routinely done?
No, so breast arterial calcifications can be seen on most, they can be seen with a mammogram, but they're not always reported. So if, for example, if you are having a CAT scan of your belly because you have pain and there's atherosclerosis or calcifications in the aorta or in the kidney arteries, the renal arteries, they might not really be reported because that wasn't the question being asked. Um, so when we've been looking at mammograms over the years, you can see that there's calcifications in there, but they may not have been commented on. So it's up to the radiologist or the policy of uh, where the radiology center is, whether or not they mention breast calcifications. Now, there's two types of breast calcifications. One are intimal, which means in the lining of the vasculature or the artery. Those are intimal calcifications. And the other type is medial, which means it's in the muscle, the muscle or the smooth muscle, the wall of the artery. Uh, right now, we don't have the technology to distinguish between intimal calcification on the lining or medial calcification in the muscle of the artery. And the reason that it is important to distinguish between the two is because they may mean two very different things. So let's say my LDL cholesterol is high and I deposit LDL cholesterol into the arteries. Well, that's plaque. And the plaque builds up. And as we know, the artery gets narrower and narrower because you have this artery like this, and the plaque is forming a ring or a dent into the artery. And so that's atherosclerosis. And when it's been there for a while, the body treats it as an injury and deposits calcium in there. So that kind of calcium, calcium in the intima, the lining of the arteries, means you've had an injury from atherosclerosis and now you have calcifications. And it tells us that you have atherosclerosis. And if you have it um, in one artery in the body, chances are you could have it in the coronary arteries, right? Or you could have it in the brain or here in the carotid arteries. Um, so, but when we look at a mammogram and see calcifications, we can't tell, is that in the lining or is it in the wall of the artery? Now, uh, in the past, the way we've looked at it is, well, if it's in the lining, then you have atherosclerosis, but it's in the wall of the artery. It's not atherosclerosis. That's just associated with age. You just dump calcium in there, but it's not that simple. The older you get, The more calcium you put into your arteries, the unhealthier you are. If you have diabetes that's not well controlled, or hypertension, or high cholesterol, or you smoke cigarettes, or you live in high pollution areas, you have systemic damage in the body, and you dump calcium into the arteries, into the wall of the arteries, all of the arteries in the body. Okay, so you do that, but what does that have to do with the heart? Well, it turns out if you put calcium into the walls of the arteries, this is the muscles that line the arteries, um, not the lining. Um, you you make the arteries stiffer. So think about this. If your arteries are stiffer and your heart is trying to pump against this stiff artery, which has calcium and it doesn't expand, it's not as flexible as it should be, then you're putting a strain on the heart. And so it points to heart problems, but in another direction, not like blockage of the arteries. So this is a lot of detail. All of this is to say that when you see calcifications on a mammogram, we can't tell if it's from atherosclerosis or if it's lining or if it's in the walls of the artery as opposed to the lining of the artery. But either way, it's a red flag and it says, pay attention. Are the blood pressures up? Is the cholesterol up? Is glucose controlled? Are you pre-diabetic? Because pre-diabetes puts you at, it's not like one day you're pre-diabetic and you have no risk of heart disease, and the next day your sugar goes this high and now you're diabetic and you have a risk. It's a graded risk. It just gets the higher the sugar, the less healthy you are, right? So one way for us to look at these calcifications in the breast arteries is here's more evidence that we need to pay attention to um, uh, all, uh, all risk factors for heart disease.
Very interesting. I'm guessing that for those that are listening to this, the question is, so is a breast calcification different from a breast arterial calcification? And then companion to that, is there a dietary component to this? So is this something that women who consume a lot of calcium containing products are more, if they're, are they more at risk, or does that not matter?
Oh, great questions. So the first part of your question is this different from a breast calcification? So breast calcifications have been used to identify an area that's problematic on the mammogram. And frequently women are, if there's some question about calcifications, this would be in the tissue, not in the arteries. And you can distinguish between those. And then you would come back and you would get maybe magnified views on the mammogram, maybe get an ultrasound, right? Because calcifications can accompany a breast tumor. So so that's separate from breast arterial calcifications. Now, as far as getting too much calcium in your diet, if uh, if you have enough vitamin D in your diet, most people with high levels of vitamin D, meaning between 35 and 60 nanograms per deciliter, will absorb plenty of calcium from their fruits and vegetables. If you do eat fruits and vegetables, and you will absorb that calcium. Now, for reasons we don't know, some people will dump calcium into the arteries, and it probably has something to do with overall health. Um, and if you have for example, if your sugars are high, but you're not even diabetic, but your sugars are too high, um, or your blood pressure is not controlled, then that calcium you absorb will may go into the arteries, into the muscle walls of the artery. And so um, we think that now when people take vitamin D, they should also take it with K2, vitamin K2, which they're often sold together now, um, because vitamin K2 can help prevent you from putting calcium into the arteries.
Interesting. So good tips for those of you that are listening, not necessarily caused by diet. There are things that you can do to supplement vitamin D. So I just wanted to emphasize that with K2. Um, you know, curiously, for women who have had breast calcifications, if they have some concern about breast cancer, is this something that is typically benign? Should they be worried about these things? Just follow them? What is the thought process on that or the recommendation?
So you're saying if a woman has had breast cancer?
If she has not been diagnosed with breast cancer, but does have breast calcifications, is this something that she should follow up?
Okay. So if she has breast arterial calcifications, um, that doesn't mean that she's at higher risk for breast cancer.
Got it.
So what is in the arteries is not related to your risk of breast cancer. It's more related to your possible risk of heart disease.
And is there, so with breast arterial calcifications, at least some of the literature would suggest that you could be at risk for stroke or heart failure. Is there one that's predominant versus the other? So more stroke versus, say, heart failure, or does it necessarily vary from
Um,
person to person?
Yeah, we don't have enough data yet, so we just have suggestions because one of the things is it's difficult to predict um, if you have breast arterial calcifications, whether you're going to have higher more of a risk of a heart attack, a stroke. Let's treat dementia, the blockages up here, that matters too, or heart failure. So it's hard to predict that, and I'll tell you why. Right now, most places that do mammograms can tell you breast arterial calcifications present or not present, or maybe mild or severe, right? But they don't really quantify it. What we really need to know, what could help us predict future disease, is if we could say, well, you have we added it all up and it's 5%, or it's 75%. And if it's 75%, you're more likely to have this or that. So we're in the very early stages because we don't quantify it right now.
So curious about how this can be used clinically. So let's assume that I'm your patient. I come in and you've discovered that I have breast arterial calcifications. What is the next step?
Yes, so the next step is to discuss the calcifications with you to tell you, number one, they have nothing to do with your risk of having breast cancer, but that when we see breast arterial calcifications, it's an indication that um, you are not as healthy as maybe we thought you were. Or, for example, we've your LDL cholesterol, the bad cholesterol, has been high for years, and we've been like, let's try diet, let's try this, let's not take a medication to bring down your LDL. This might be a tipping point where you would say, yes, you know what, maybe I do. I've tried this, I've tried that, and now we have evidence that I have calcium in the arteries and that I need to be more aggressive about treating risk factors. For example, if I'm pre-diabetic, I I really have to make changes to lower that because we've got something objective that's showing there's some pattern of injury in the arteries, and we're getting a glimpse of your arteries through your breast. So what I see is an opportunity for counseling uh, to treat risk factors aggressively.
Does it, I know that in the past we've talked about women and men having their calcium score measured. Is there any connection there between the calcium score and breast arterial calcifications? So what if you had a high calcium score? Let's say it's over 100. Should you expect that when you have that mammogram that you might also see some evidence of breast arterial calcifications?
Absolutely. And remember, if your coronary calcium score, you have a CT coronary calcium score, if your score is 100, you've got atherosclerosis that has been calcified and it's sitting in the coronary arteries. You should absolutely expect to see it in the breasts. Conversely, if you see something in the breasts, there are some small studies that say, yep, this directly correlates with your CT coronary calcium score. So there is an association. So it's another piece of evidence.
So, so if you are someone who has just had your mammogram, if you're fortunate enough to have a radiologist that actually puts this in the report, and we'll get to that in a minute, uh, the next phase might be if you had never had that CT to determine whether you've had your calcium score to actually see if there is a calcium score that is also concerning, right?
Yes. So yes, one thing you can do, this is something we usually do in 50 years old and up, is a CT calcium score. So it's not covered by insurance, but it tends to run around $100, $120 at various hospitals. And sometimes they run a special. So you pay out of pocket and you need a prescription from your doctor. And it's a very quick CT scan because remember, CT scans are associated with a lot of radiation. This is a very quick one because all they're doing is really looking at the coronary arteries. And they have a way to quantify the score in the coronary arteries. And what you hope is your score is 0 and that there's no calcium. Um, and if your score is 1, if there's even just a little bit of calcium in there, it means that you have atherosclerosis and you should consider going on a statin to lower your LDL, or whatever it is to lower. I mean, you need to pay attention to the LDL so that we can start to reverse that. Because when the LDL in your body goes down, let's say you change your diet or you go on a statin, LDL goes down, you start pulling it out of the arteries. And those plaques that are in there that are trying to block the arteries, they get smaller and smaller and smaller, and you're just left with a scar. Now, if you if one thing to remember with the coronary calcium score is if your score is 0, it doesn't mean necessarily that you have no atherosclerosis because you could just have LDL deposited in there, the bad cholesterol, but it hasn't been in there long enough to be an injury in which calcium was deposited. So we can't really see fat very well, like tiny bits of fat that are causing a plaque in the arteries. Um, so it's great to be 0. Sometimes if you've been on the fence about taking a statin and your coronary calcium score is 1 or more, or let's say like the other day, one of my patients, it was 700. She was like, that's it. I'm going to take the statin. I've done everything I can through diet and exercise. This is genetic, and I can see the evidence now, right? Because when we think about it, when we talk about cholesterol and possible heart disease and so on, it's often abstract. But when you have something in your hands that you can see, that can help you make a decision.
You mentioned something about genetic and genetic predisposition. Is that so? Let's say I'm a runner, I eat a Mediterranean diet, go in and I have my mammogram and they see some breast arterial calcifications. Wait a minute. How can this be possible? I do
Yes.
everything the right way. Is there a genetic predisposition?
There's not a genetic, as far as we know, there's not a genetic predisposition to breast artery calcifications. They would be secondary to something else. high sugars and so on. So if you let's say that, just like you said, you eat well, you exercise most days of the week, you're at a healthy weight and so on, but you have breast calcifications, then it makes me wonder, have your sugars been elevated for a long time? Has your LDL, we've treated it like, not too high, but actually it's an issue. So another clue.
Yeah.
Yeah.
So it really does give us, so breast arterial calcifications really do give us some really important insights into our overall cardiovascular health, even if we think that we are very healthy
Yeah.
and we may generally feel very well, but that is a really good insight to help us to take the next step and possibly do something before we suffer from a more extreme circumstance, which could impair our overall health, like a stroke or heart failure, what have you. The radiology, cardiology, and primary care communities, how well do they collaborate with these sorts of things? Do they communicate with each other, or should we be the ones that advocate for that?
I think we need, as patients, we need to advocate for ourselves. So, unfortunately, conventional medicine, we work in silos, don't communicate very well with one another, let alone people outside of our silos. And that's the system. Um, so, but you may find a cardiologist who's very interested in breast arterial calcification. Our radiologists at Thomas Jefferson have been enthusiastic about looking at breast arterial calcifications because they want to be able to prevent heart disease in women. So, but it's something uh, you can ask your radiology center, do they comment on the presence or absence of breast arterial calcifications, BAC? Now, insurance should pay for this. And if what I would say is, because it's not, um, we're not advanced yet in predicting uh, whether or not you will have a stroke or a heart attack or heart failure with this. If radiology says, "Oh, we charge to tell whether we tell you or not about breast arterial calcifications," I'd say just wait, because it's going to be covered in no time. I'd like to give you an example of um, uh, something in radiology that could help us. I'd like, if those of you who are listening, I'd like you to go back. If you've had a CAT scan of your chest because you had a cough that didn't go away, you had pneumonia, or maybe you had a CAT scan because you had of your belly because you had a gallbladder attack, whatever it is, go back and read all the fine print, not just the conclusion, like, yes, there are gallstones, or yes, there's a pneumonia in the right lower lobe of the lung. Take a look at the part that says vasculature or arteries or blood vessels. And does it say that the mild atherosclerosis or a few calcifications or moderate calcifications? You got your answer. That is like a calcium score. It's like, oh, if you have it in the aorta or in the renal arteries, the kidney arteries, or and it's a, by the way, there's your answer. It means you need to get down to work to decrease the size of those plaques in the arteries. And often, and I used to do this in the past, I'd look at a CAT scan and I'd be like, oh, okay, there's gallstones. We're going to do this, this, and this. Or, oh, there's a liver cyst. Um, but I wouldn't read the fine print where it would say, oh, there's mild atherosclerosis. Or if it was there, I'd be like, well, everybody in this country has atherosclerosis. If you live in America, we have well, wait a minute. We can do something with that information, and you don't need to get an extra test for it. So I'd like you to look. And if I may, Jerry, go on. Um, Something I really worry about is dementia. And, it's not like if you have blockages in the arteries of the heart or the aorta, and maybe small blockages, it's not like, whoa, well, it skipped the arteries in your brain. Of course, it's in the arteries in your brain. It's everywhere, right? And those arteries are so tiny and they are closing. And if the artery closes, that means the tissue downstream didn't get any oxygen. So that little part of your brain is gone. And this happens enough time and we're demented. And I think that so many of us have blockages in the small vessels, the tiny vessels in our brains. And we need to think about that as well as heart disease.
That's great advice. It's interesting that you mentioned that because having read a few reports myself, both for myself and for my husband, interesting that I always do read the fine the fine print to see what other things have been revealed in whatever radiologic procedure that has been performed. And it could be something that seems relatively benign, as you say, chest x-ray because there's a cough, or maybe it is a sinus infection and we want to make sure that we're taking care of things properly. But I do look at the detail. That's really good advice, and it's free, right? So that comes with the package. It, at least from what I have read in the literature, a lot of what happens with radiology is, as it pertains to breast arterial calcifications, it's not always reported. So in fact, it's reported, I believe the number was less than 15% of the radiologists will report this.
Yes.
So if you're a woman and you want to advocate for yourself when you're having a mammogram, is it
Yes.
okay to say, please report on breast arterial calcifications?
Yes, absolutely. You can ask for that.
And that might make sense because you may not go for the calcium score, and perhaps you're so healthy that you've never had to have a CAT scan or any other assessment from a radiology department. But this could be your opportunity. If you're 40, 45 years old, you're going for your mammogram, not a bad idea to ask for that information.
Yes.
Maybe you have some insights. That's your baseline. Things look great. And maybe they stay that way for a very long time. But if not, at least you know that you need to make some lifestyle changes in order to address what might be an emerging issue that impacts your heart health.
Yes, it's information, and the more information we have, the better. We may not know how to use it. We may not know exactly what it means, but I'd like to know if I had breast calcifications at this point, breast artery calcifications.
So this is great information, how your mammogram can actually have an impact on your heart health. What a great way in which to get more information about your cardiovascular health, and to do that as you continue to move through life's transitions. So we know that as women, enter their 40s, 50s, and 60s, that we see the decline in estrogen. Women are worried about their metabolic health, and this is just one more tool that we have in the tool chest to assess our overall metabolic health.
Yes.
Catherine, I want to thank you once again, Dr. Catherine Sherif, my co-host and guest on the Love Mia Vita podcast. Please tune in again, and please check out our other podcasts. I believe we are over 100 at this point. So many podcasts, many with Dr. Catherine Sherif. We'll look forward to seeing you next time. And until then, remember to love Mia Vita.
Take care.
Thank you for joining us on the Love Mia Vita podcast. Love Mia Vita means love my life, and that is a mantra we should all live by. Please like and subscribe wherever you get your podcasts, and remember to follow us on social media and on fempharma.com. Thank you, and be well.